Greetings, everyone, and welcome to the EKG case for the week of 2012. And this is Amal Matu, and I'm actually not at the University of Maryland this week. I'm actually down in North Carolina on a family vacation. And for those of you that are not familiar with, if you're outside the country or maybe you're one of those West Coasters, you may not be familiar with the Outer Banks in North Carolina. So let me show you a map. This is North Carolina and the Outer Banks bordering the Atlantic. And this is Kitty Hawk, where the Wright brothers created and flew the first airplane in history. So there's a lot of history, but the main reason we're down here is because of this bank. It's kind of like an island, I guess, or a series of islands abutting the Atlantic Ocean. And that's where I am right there, in a place called Corolla. Or down here they call it Kerala, which sounds a bit odd, but that's where we are. It's a really, really beautiful beach, and it is fairly low-key, so it's kind of a nice place to be. But anyway, the reason I bring that up is because, as you may notice, I'm using my cursor here. I forgot to bring my iPad, so I'm not going to be using fancy graphics or anything like that for this session, but we don't need any stinking fancy graphics to do some EKG teaching. So here's a case. This is case 1, and there's a series of cases I'm going to show you to demonstrate one simple, very important point. Okay, so here we go. 63-year-old woman who comes into the emergency department complaining of lightheadedness. There is the 12-lead EKG, and let's just focus on the rhythm for a second. She's got a right bundle and maybe actually a bifascicular block, but skip over that. Why don't focus on the rhythm? In this case, the machine's calling it atrial fibrillation, and the treating physician initially called it atrial fibrillation as well. And you look down here and you see a somewhat irregular series of QRS complexes, and when you see irregularly irregular, you have to remember that there's 3 possibilities, not just one, not just atrial fibrillation. The 3 possibilities for irregularly irregular are atrial fibrillation, multifocal atrial tachycardia, and atrial flutter with variable conduction. And you're going to miss a flutter with variable conduction if you don't know which is the best lead for detecting P waves. Now, if you're in Las Vegas and somebody asks you to put your bet down on which lead on the 12-lead EKG is the best lead for detecting P waves, a lot of people are mistakenly going to say lead 2. And the reason why so many people think it's lead 2 is because the machine oftentimes gives you lead 2. And it's because the machines are programmed to give you lead 2, not because they want to tell you if there's P waves, yes or no, but because the machines want to know whether the P waves are upright or not. Because if they're upright P waves, that's suggestive of a sinus rhythm. So the machine's not interested in knowing whether the P waves are there or not. The machine's mainly interested in knowing if the P waves are upright or not. If they're upright, then that suggests a sinus rhythm. If they are inverted in lead 2, that suggests an ectopic atrial rhythm. But unfortunately, because the machine often gives you lead 2, or pretty much always gives you lead 2 as the main rhythm strip, people mistakenly put their money down on lead 2 as the best lead. And if you're in Vegas and you put your money down on lead 2, this is what's going to happen. You're going to end up broke, okay? Because lead 2 is not the best lead for picking up P waves. The best lead for picking up P waves is lead V1, all right? It's lead V1. V1 is usually, nothing is 100%, but lead V1 is usually your best lead at picking up P waves. And if you think about it, lead V1 sits at the right upper sternal border, which pretty much overlies the sinus node. So if you ever want to know whether there's P waves or not, lead V1 is usually going to be a better lead than lead 2. Now, I'm not telling you not to look at the other leads. As the person who taught me a lot about EKGs, Edward Chung, really, really smart cardiologist, back when I was in residency, used to teach all of us. He said, look up, look down, look all around, look in that entire 12-lead EKG for P waves, and when you look around, you're going to find that lead V1 is more often the best lead. And when you look up here, what do you see? You see the machine's wrong. There's actually P wave, and another one, and then maybe something buried in there, but then there's another one. If you have your calipers, it maps out nicely to a rate of probably about 300, which means that this is actually atrial flutter with variable conduction, and the machine miscalled this atrial fibrillation. Now, you might say, well, that's not a big deal, right? Because what's the big deal in mistaking atrial flutter for AFib? AFib and aflutter are pretty much cousins. They live together in many cases. They have the same type of underlying causes. They get treated the same way. It's not a big deal making that mistake. Well, let me show you another case here. Aflutter, by the way, is probably the most commonly missed tachydysrhythmia because people don't look for P waves carefully. Here's a 50-year-old man with palpitations. Of course, once again, the EKG machine gives you lead 2, and the machine didn't see any good P waves, so the machine calls this SVT. But now you know, take a look up in V1, there's a P, and there, and there, and there, and there. This is actually atrial flutter, and once again, V1 is your money lead. It gives you the best look at what the sinus node, or what the atrium in many cases, is doing. You can get an appreciation for some P waves that are showing up in lead V2 as well, but again, it becomes very obvious when you look at lead V1. So now you think, well, you know, atrial flutter versus SVT, that's not a really big miss, because even if you mistakenly do call this SVT, you're probably going to give the patient some adenosine, and then once you give them adenosine, then the flutter becomes very obvious, and you treat the patient appropriately. So no big deal. Well, let's go to another case. Here's a 21-year-old woman that presented with lightheadedness. And this time, the EKG machine once again mistakenly looked at lead 2 and called it sinus tachycardia. Well, there's some P waves going on down there, and I think it probably saw that. And maybe there's some blips right there that it was looking at, calling this sinus tachycardia. But what do you know? You look up in V1, and there's a beat and a blip there, and a blip there, and maybe something buried, and then there, and then there, and then there. This is another example of atrial flutter with 2-to-1 conduction. It's a little bit variable early on, but then it goes into 2-to-1, and once again, lead V1 is your best lead. Now, V1 is not your best lead in every case, but in many cases it is, and I'm showing you a series of cases here where mistakes were made because people didn't focus in on lead V1, and the machine didn't do that either. So this is a bigger deal. When you miss a flutter and call it sinus tachycardia, that is a bigger deal because patients are inappropriately not treated for atrial flutter. They may get a lot of IV fluids because people think it's sinus tachycardia. In fact, here's another nice case, 48-year-old woman who came into the emergency department complaining of palpitations, and the machine once again calls this sinus tachycardia because it's probably looking there at lead 2. I don't know what it's looking at actually. Maybe it thinks that there's a P wave there and a P wave there, and so sinus tachycardia. Maybe it looked down in V3 and thinks that those are P waves. But when you look in V1, your money lead, again, you notice P wave, 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 and so on. All you do is you get your calipers out, you map it out, and you know that if things map out, they've got to be called atrial beats. And this is another example of atrial flutter with variable conduction. This is a patient that presented with a stroke. The patient was evaluated by the neurology team. They decided not to give thrombolytics, but they admitted the patient to the neurology unit, and the patient sat in the neurology unit with this mistaken diagnosis of sinus tachycardia for almost 24 hours before they realized that it was actually atrial flutter with variable conduction. It's a little bit variable up here, but people thought it was just sinus tachycardia because that's what the machine said, and also because everybody looked down here at the inferior leads, and they didn't take a good close look at lead V1. This was the initial EKG, and if they had looked closely at the initial EKG's lead V1, they would have made the proper diagnosis of flutter many, many hours earlier. And here's yet another example. This is a 57-year-old man that got sent to the emergency department from, over in the cancer center. The patient had received some chemotherapy and had some vomiting, certainly not an atypical story, and he came in with a tachycardia with a rate of about 150 or so. So everybody thought he was simply dehydrated because the machine was calling it sinus tachycardia. And the machine gives you a lead 2 as the rhythm strip, and it looks to me like there's just a whole bunch of junk down there. I don't even know what it's calling sinus tachycardia for, but that's what the machine called it. and nobody bothered to do anything more than to go with the machine's interpretation. Had they looked closely at the money lead, V1, the diagnosis would have been very clear. There's a P wave, there's another one, and another one, and another one, and another one. This is atrial flutter with 2-to-1 conduction. So what happened with this poor patient that had just received chemotherapy? The patient sat in the emergency department, and I'm not going to say where, but the patient sat in the emergency department and received 6 liters, no joke, 6 liters of normal saline because they thought he was in sinus tachycardia due to dehydration from all his vomiting. They gave him 6 liters of IV fluids, put him into heart failure, and then they finally realized when his heart rate didn't budge from 150 despite 6 liters of IV fluids, they finally took a better, closer look at the EKG, and maybe they looked up at lead V1 finally and said, hey, wait a second, those little spikes, those are P waves, and they're mapping out at a rate of 300. This is not sinus tachycardia. He's actually been in atrial flutter the entire time. He never needed 6 liters of IV fluids. Maybe he needed a little IV fluids, but this guy needed some beta blockers and calcium channel blockers to bring his ventricular rate down. And eventually he ended up converting, but not before he went into heart failure, and this poor guy ended up in the CCU being treated for fluid overload, iatrogenic fluid overload. Why? Because people didn't look at the money lead. So, very, very simple take-home point from this week's EKG Pearl. Actually, 2 points. Number one, never, actually 3 points, sorry. Number one, never believe your EKG machine. Always look at the EKG machine on your own. Look up, look down, look all around. Take-home point number 2, atrial flutter is the most commonly missed tachydysrhythmia. Whenever you see a ventricular rate of about 150, now I always say plus or minus 20, be very paranoid of flutter. Look up, down, look all around for those atrial flutter beats. And take home point number 3. Always look in lead V1. I don't care that the EKG machine always gives you lead 2 as a rhythm strip. It shouldn't. It's a mistake that the machines are programmed to give you lead 2. Don't rely on lead 2. I'm not saying don't look at it. Sometimes lead 2 is a great lead. But always, one more time, always look at lead V1, because there are many times where lead V1 will give you the answer about what the atrium's doing, and lead 2 will throw you off. So make sure to look in all of those leads, pay special attention to lead V1, and don't just rely on lead 2 just because the EKG machine's giving that to you. All right? So I hope that case was helpful, and I'll be back home next Saturday, back home in Maryland, and I'll get the fancy graphics back on. I hope this EKG case was helpful. Until next week, take care.